Selective fetal growth restriction complicates about 10% of monochorionic twin pregnancies. It's subdivided into three types based on the umbilical artery flow pattern in the smaller fetus. Type 3 SFGR, which is characterized by intermittent absent or reversed end diastolic flow, makes up about a fifth of all SFGR. The objectives of the present study were to assess the factors associated with spontaneous fetal death in a large cohort of pregnancies complicated by type 3 SFGR, and to evaluate how these factors can be integrated into a prenatal management protocol. This was a retrospective review of monochorionic diamniotic twin pregnancies complicated by type 3 SFGR that were managed longitudinally at 9 centers. Type 3 SFGR was defined as estimated fetal weight of one twin less than the 10th percentile, and intertwin weight difference of greater than or equal to 25% in combination with intermittent absent or reversed end diastolic flow with a smaller fetus. Pregnancies with type 3 SFGR, complicated by spontaneous single or double fetal death, were compared to pregnancies with survival of both twins. One set of ultrasound measurements was retrieved for each twin pair at 5 gestational age time points, if available. At each time point, the investigators assessed fetal weight, Doppler, amniotic fluid, and development of TTTS. Compared to pregnancies with double survival, pregnancies complicated by fetal death were referred to expert fetal centers early in pregnancy. Earlier gestational age at diagnosis, oligohydramnios in the smaller twin, and deterioration in umbilical artery Doppler were associated with an increased risk of fetal death, as was larger intertwin fetal weight discordance. Normalization of umbilical artery Doppler was associated with a lower risk of fetal death. A prediction model, including umbilical artery Doppler deterioration and gestational age at diagnosis, could identify 3 groups: a low-risk group, in which the risk of fetal death was 6.8%, an intermediate-risk group, with a risk of fetal death of 16.3%, and a high-risk group, with a risk of fetal death of 58.3%. Multivariable analysis demonstrated that none of the parameters maintained statistical significance. Type 3 SFGR is associated with the high risk of fetal death. A prediction algorithm can help to identify the highest risk group, which is characterized by Doppler deterioration and early referral. Further studies should investigate the potential benefit of fetal surveillance and intervention.